Hey guys, so in this video I am going to talk about the basics of knee ligaments. So I am covering the topics of mainly lower limbs, and I have covered the pediatric hip disorders, and in this video I am going to talk about the knee ligaments and the injuries, and after this I am going to start about the trauma of lower limb. So let's see. And then osteoarthritis and the club foot, that is also pediatric foot disorders. So let's see. So there are mainly three types of ligament, but before going to that we have to learn about the locking and unlocking of the knee. What is the difference in locking position and unlocking position? So knee will be in extension when it is locked, and in flexion when it is unlocked. When will be knee in the extension? So in the standing mainly knee will be in the extension, and in the sitting position knee will be in flexion. And the reason being why knee locking is occurring, because quadratus femoris and ligaments inside the knee and femur rotated medially over the tibia, that will cause the locking of the knee. And here in unlocking the reason is mainly the popliteus. Okay, so if you have to see by diagrammatic representation I am seeing locking versus unlocking of the knee joint. Okay, let's see if we can find, yes, this one. So in this diagram you can see in standing position means when knee is in the extension, what will happen, this quadriceps femoris tendon will cause the locking mechanism. And in flexion mean when we are sitting, what is causing this unlocking, that is popliteus. And here the tibia femur will rotate medially over the tibia in the locking position. I am just seeing if any. This movement is aided by the oblique pull of the ligaments of the knee joint and contraction of the quadriceps muscle. The ligaments are pulled taut when the knee joint is locked in place during standing. Here flexed, and when extended it will rotate medially, and when extended it will rotate laterally, and the popliteus unlocks knee when flexed. Okay, I think this is a good diagram to have here. And in theory wise you can see that knee locking is quite literally when your knee locks up momentarily, inhibiting your ability to move in any direction. This can also be described as catching, where it feels as if your knee gets caught during extension or flexion, the knee giving out, or as a popping sensation with knee movement. Unfortunately, there is no key or secret trick to unlock your knees, though various treatment exists. I don't think this is what I need to learn right now. This will be, I think, during last 30 degree of extension during initial stages of flexion. Medial rotation of the femur, lateral rotation of the femur helped by quadriceps femoris, helped by popliteus, mainly vastus medialis, and as standing at attention the ligaments are taut and the ligaments are relaxed. Okay, I think this is also a good diagram to have. And this one is also a good one. Sorry. So let's understand this further. Where will I put? Okay, we can put here, insert image. Locking and unlocking mechanism here. Okay, so let's learn this concept again. There is two mechanism in the knee joint, locking and unlocking. First we will learn about the mechanism, what causing this locking and unlocking and in which position. Let's start from this one. What will happen when we are in this standing position, means we are in the last 30 degrees of extension. The quadriceps femoris and mainly the vastus medialis will contract, so it will cause the femur to rotate medially over the tibia and the ligaments are taut. So femur will rotate over the tibia medially and the ligaments are taut, so it will cause the locking of knee. And in the initial stages of flexion, when we are sitting, the ligaments are relaxed and the femur will rotate laterally over the tibia by popliteus. So this will cause unlocking of the knee. In locking, mainly the ligaments are taut and femur is medially, so it will be locked. It won't allow any movement. While in flexion, ligaments are relaxed and the femur is in lateral, so it will allow some of the movement. So seeing the basic difference, the position means posture is standing and knee is in extension. So quadratus femoris and ligaments will cause locking of knee, and here in unlocking it will be flexion, sitting position, and popliteus will cause lateral direction and ligaments will relax and it will cause unlocking over the knee. Now there is 3 types of ligaments here. Let's see. Meniscus, collateral ligament, and the cruciate ones. Now meniscus will cause the stability while in rotation, collateral will cause in coronal plane, and cruciate will cause in sagittal plane. You can remember that collateral cause coronal plane stability. Coronal means it will cause stability in the lateral and medial direction. Yes, and the cruciate one will cause in the sagittal plane, means anterior posterior direction. Now let's see these 3 ligaments one by one. First is the meniscal ligament injury. So there is 2 meniscal ligament, medial and the lateral one. So medial meniscal, lateral meniscal, M and L, M in short form. There is term called as degeneration and there is trauma. So both will more occur in the medial side. Why? Let's see the reasons. So more weight bearing towards the medial side, so medial meniscal ligament degeneration will happen early. And why in trauma also medial one is the most common injured than the lateral one? Because there is two mechanisms. First is twisting injury, in twisting injury, and the second one is the mechanism of injury, either it is valgus or varus. So these two will mainly happen in the medial than lateral. Why? During the twisting injury, what will happen that medial collateral ligament and medial meniscus both are attached. So both are more fixed and less free. So if any ligaments are more fixed, it will they are more prone to damage in the twisting injury because they won't be able to move, so chances of rupture will be more. So in twisting injury, medial collateral ligament and medial meniscus both are at high chances of getting injured due to they are fixed and less mobile compared to the lateral one that are free from the lateral collateral ligament, less fixed and more free. And in valgus and varus injury, what will happen? Valgus means the blow or trauma will be from the outside, means lateral part, and the knee will go medially and the tibia will go laterally. It is called as the valgus injury. So knee will go medially, that's why medial ligaments like medial collateral and medial meniscal ligament both are more prone to injury, and the most common injury is valgus than varus. That's why medial ligaments, medial collateral and medial meniscal ligament are more prone to injury than the lateral one, which are mainly damaged during the varus injury. And this two mechanism you will also see in the collateral ligament injury. We will see that in collateral there are also two ligaments, medial collateral and the lateral collateral ligament, and in same way medial one is attached with medial meniscus and lateral is free from lateral meniscus. That's why in twisting injury also there is chances of damage to medial collateral ligament more than lateral collateral ligament. As we have discussed, it is less mobile, more injured, more mobile, less injured. And in mechanism of injury, same will happen. Valgus mechanism is more common than varus one. That's why medial collateral ligament will injure more compared to the lateral one. So this two mechanism of injury, varus, valgus, and in twisting injury also medial side, medial collateral and medial meniscal both will injured more than the medial lateral ones. Okay, so this you will see now. But there is some exception. In sports injury, means any type of injury, MM tear is more common than the LM tear. But if the cause is not trauma and some other pathology like meniscal cyst or discoid meniscus, then LM tear will be more than MM tear. So this we have to remember, that if it's due to pathological cause like any cyst or discoid meniscus, then the lateral meniscal injury will be more common. Now, and in degeneration also, MM degenerates more than the LM, but post partial meniscotomy, LM remnants will degenerate more than LM remnants. So these two exceptions we have to remember. Now sign and symptom. What will happen? Meniscus are responsible for mainly rotational injuries, and there will be history so in this case there is history of playing cricket, and while playing it he slipped on the wet grass and there is twisting injury. Twisting injury means fat snapping sound will occur, but in this what will happen, that pain is there, no doubt, but patient is able to bear his own weight post trauma. This is an important line. That's why even after trauma he is able to go home without any help, climb 3 fold. There is too much pain, no doubt, and patient came with a walker. So patient is still able to bear his own weight in meniscal injury, while compared to this collateral one. There is also twisting injury at the knee, fat snapping sound, and here it is a young female in early 30s, wet floor. Here is also wet floor, and to avoid slippage, accidental pressure in the at the knee joint and twisting injury will happen. But here after post trauma she is not able to bear own weight, not able to move at all. There is severe pain and clicking sensation when she tries to bend the knee on, and she is on the wheelchair. And why? Because these collateral ligaments are providing stability in the coronal plane, means lateral median direction. Here the test will be McMurray's test, that is joint line tenderness. That is diagnostic, and Epley's test is now obsolete. And in all ligament, investigation of choice will be MRI, gold standard will be arthroscopy, and management will be meniscography or meniscotomy, depends upon the site where it is injured. So we are dividing into 3 parts: outer 1/3, middle 1/3 and outer 1/3. But outer 1/3 it is red white and the white, and the direction of blood supply is this one. So here it will be more blood supply, so red, slightly less blood supply, so red white, and very less blood supply, so it is white. So in this two, where it is blood supply enough, we can do meniscography, and here we have to do meniscotomy. So here patient will able to maintain or bear the own weight, but the management is always the surgical one, while here in collateral ligament injury the management is surgical one. Investigation of choice is MRI. So we will give painkillers, NSAIDs, rest, immobilization, cold packs and elevation. So this is price management. And most common ligament to undergo tear or due to trauma, it is MCL. So this differentiating point we have to remember, and we have skipped the clinical test. So here obviously the valgus stress test, and here it will be varus stress test. Now the cruciate ligaments. So cruciate ligaments are 2 ACL and PCL. How this naming is done? So ACL, 2 points we have to remember. It will attach tibia anteriorly. So come to the posterior part of femur, intertrochanteric point of femur, and will attach to the tibia anteriorly in the tibial spine, and in posterior cruciate ligament opposite will happen. So it will attach to the tibia posteriorly, and there is similarity and differences. So let's see 6 similarities and 6 differences, and then we will see the sign and symptom and the management part. So both are in the knee joint, intra-articular, intracapsular, but they are extrasynovial, means they are in the joint cavity, intra-articular, inside the capsule also, but extrasynovial, and they are providing the stability in the sagittal plane and the nerve supply and the blood supply. We have to remember that medial geniculate artery, which is a branch of popliteal artery, is supplying this, and middle geniculate artery, middle, it's middle, and the posterior articular nerve, that is branch of the tibial nerve, is supplying this. So geniculate and articular, geniculate is middle geniculate and articular is the posterior articular nerve. This two thing, I think it is very very important, and you can forget these names, middle geniculate artery and the posterior articular nerve. Now the difference part. So in difference is ACL and PCL. PCL is thicker one, and that's why it is obviously better visualized, and most common site of tear and mechanism of injury is also different. Here it will be mid substance, it is damaging more, and here it will be the femoral attachment. Here it will be hyperextension injury, and here it will be hyperflexion injury. Now you can see from the function that ACL prevent access, ACL is anterior, so anterior translation of tibia over the femur. And when will it happen? So downhill or downstate. And ACL prevent a posterior translation of tibia over femur. When will it happen? Uphill or upstairs. And that's why in hyperextension ACL will injure more, and in hyperflexion PCL will be injured more. So this is by mechanism only, and clinical test is based on this anterior drawer test and posterior drawer test. Anterior drawer test, knee will be in 90-degree flexion, and the latchman test is the same, but knee will be in 20 to 30-degree flexion when it is a most comfortable position of the knee joint, because capsular volume will be maximum. Sign symptoms, there is case that it will mostly present in the casualty, and hugely swollen knee will be there, because it will cause hemarthrosis, bleeding will be present. So most common cause of hemarthrosis is knee is actually ACL tear. And how this injury will occur? We know that it is a hyperflexion injury, and that's why hit in the front, and feel like the lower two knee is gone, and was not able to bear his own weight. Investigation is MRI, gold standard arthroscopy. Management will be arthroscopic reconstruction we have to do, and the donor tendon graft will be from the semitendinosus and gracilis.